So today we're going to talk about antipsychotics. Okay. In some books, this chapter is combined with the chapter on lithium. Okay. But here we're just going to focus on antipsychotics. So antipsychotics are also known as neuroleptic drugs, anti-schizophrenic drugs, and also previously known as major tranquilizers. But nowadays we just prefer using the term neuropsychotics. And generally speaking, antipsychotics are used to treat schizophrenia and other psychotic and agitated states. So a patient with schizophrenia, usually they have a few symptoms. Okay, for example, they might have a delusion or hallucination. So when they have a delusion, there are many types of delusion. So for example, you can have grandiose delusion. Okay, so grandiose delusion is when someone has a false, unshakable belief that is not shared by people from the same background. Okay, so that's how we usually define delusion. Okay, so delusion is a false, unshakable belief. Okay, that is someone possessed that is not shared by people from the same background. So grandiose delusion means someone is very grandiose. Okay, someone becomes grandiose. He believes, for example, that he's God, or he's a king, even though he's not. Okay, or he feels that he's a prophet or something else. Okay, that is not shared by people from the same belief, meaning that people from the same background generally will not believe him at all. Okay, they will think that he is not speaking the truth. Okay, because they from the facts that we have, he's wrong. Okay, means he's not saying the truth about himself because he believes falsely about himself. So that's delusion. And then we have persecutory delusion. Okay, someone feels that he's being persecuted, for example, by the FBI, CIA, NCIS, etc. So he feels that he's being pursued. Okay, even though it is not true. Okay, no one is pursuing him, but he feels that way, in that way. So that's called persecutory delusion. So there are many types of delusions, and then hallucinations. There are a few types, mainly in schizophrenia. Our main concern is auditory hallucination. Okay, auditory hallucination. So auditory, there are many types. Okay, so auditory hallucinations, of course, is something when you perceive something without an external stimuli. Okay, you perceive something that is not shared by other people. Okay, for example, you hear something that other people cannot hear. You see something that other people cannot see. Okay, and you feel something that's called tactile hallucination. Okay, you feel something creeping under your skin, for example. You feel like there is a spider under your skin, but there is not. There is no spider under your skin. So that's called tactile hallucination. You can have olfactory hallucination. Olfactory hallucination means you smell something when other people smell something that other people are not smelling at the same time. Okay. So patients with schizophrenia, usually they have delusion, okay, or they have hallucination or both, okay, and usually that persists for many months, usually 6 months, and the condition affects your normal functioning, okay, normal daily functioning, either as an individual or as a member of society, as a member of family, okay, and your work is usually also derailed or you're dysfunctional at work, okay. A patient with schizophrenia, they are dysfunctional at work, okay, for that duration. So that's schizophrenia. And then we have other psychotic, okay, meaning they also have delusion and hallucination, but not because of, but they are not being diagnosed as schizophrenia, okay. For example, they might be diagnosed with something else, for example, bipolar disorder and other conditions. And then we have the agitated states, okay, means they are being agitated for some reason, okay, so they are disturbed. So sometimes we need to give them also antipsychotics. So generally speaking, when we talk about antipsychotics, the older drugs, okay, the older ones have higher affinity for dopamine 2 receptors. Okay, they have a higher affinity for dopamine 2 receptors. So the older drugs are also called the classical drugs, okay, classical drugs, or the typical antipsychotics. Typical, okay, antipsychotics. So examples of this include chlorpromazine, fluphenazine, haloperidol, thioridazine, okay, and also trifluoperazine. So mainly these are the 10 years ago, this was still used, okay, I was still using this. Yes, this one is a bit rare, a bit rarely, okay, and this is so rare, okay, so this is also not quite rare, okay, so these ones are used, probably nowadays, not sure whether they are still being used, okay, probably if they are still being used, it's quite not frequently, and of course it will depend on the departmental budget, okay, the hospital's budget, the government's budget. Okay, if you work in a government hospital, depends on how much you have. And of course, if you're also working in a private clinic or hospital, that will depend on your patient's budget, which drugs do you give. Okay, that's for the old one. Okay, and then we have the newer drugs, okay, newer drugs. We'll talk about that later. And the newer drugs, they have a high affinity, so they like so much the serotonin 2 receptors, okay, the 5-HT2 receptors. So they like the 5-HT2 receptor, serotonin 2 receptors. So these drugs, the antipsychotics, they do not cure schizophrenia, okay, but their objective is to improve the symptoms, okay. We try to improvise or ameliorate the symptoms of thought disorder, emotional withdrawal, hallucinations, and also delusions, okay. So these patients, they are emotionally withdrawn, okay. They tend not to interact with other people. They're into their own world. So we need to give them something, okay. So So these antipsychotics is the mainstay, okay, the mainstay to treat schizophrenia. So when you give antipsychotics, usually when you give antipsychotics for schizophrenia, usually we are looking at giving the drug for years, okay? So it's not something about giving it for days or weeks, okay? So we're talking about schizophrenia here, not talking about other conditions. Okay, you might be giving an antipsychotic for a few days or just one dose, okay? For example, someone is like going amok in the ward, okay, you want to give haloperidol, for example. So of course that might be just one-off thing. So it's just a stat dose, one stat dose, and that's it. Okay. But see, that's not what we're talking about. Okay, we're talking about treating schizophrenia. So schizophrenia takes some time to diagnose, okay, and they tend to come a bit late usually. Okay, meaning it's been for quite some time before they start presenting to the doctor. Okay, so they might see other so-called alternative therapies, etc., before they finally turn up at the doctor or the clinic. So we've talked about the older antipsychotics. So older classical antipsychotics that target the D2 receptor, and then we have the newer ones. Okay, the also known as the atypical. Okay, usually called the atypical antipsychotics that tend to attack the serotonin 2 receptors. Okay, it has a high affinity for the serotonin 2 receptors. So these drugs include olanzapine, okay, anyway, let's just follow. Let's try to use an alphabetical order. Clozapine, olanzapine, quetiapine, Q, and then R, we have risperidone. And then we have ziprasidone. Ziprasidone. So usually antipsychotics, we classify them, okay? We can classify them according to the major chemical subgroups. Okay, for example, we have the phenothiazines. Phenothiazines. Usually you don't have to memorize the chemical classification. It's just for information. So for example, phenothiazines, we have a number of drugs. Among others, we have chlorpromazine, we have thioridazine, we have fluphenazine. And then the next category is called the thioxanthines. Okay, thioxanthines include thiothixine. Okay, so this is I'm not sure whether it's still being used. I think this is like a very ancient drug, so people tend not to use anymore, okay, due to some reasons. And then we have another classification called butyrophenones. Okay, so this one you can sort of like neglect this. Okay, you don't pay attention to that anymore. Butyrophenones, unless there are new indications for it. Okay, because there can always be new indications for an old drug. Okay, so an old drug, for example, can be used previously to treat malaria, for example, and then later on they find a new disease and they try a new drug. Use a new drug or an old drug. So they might treat COVID-19, for example, with an old drug like chloroquine, okay, which is an old drug, used for a totally different, not totally different, but yeah, to a certain extent, a different indication. So it used to be used to treat a malarial infection, which is a parasitic infection. So then it's currently being used to treat experimentally to treat COVID-19, so which is a virus. So we have the butyrophenones. Butyrophenones is the example here is haloperidol. Okay, haloperidol. So newer drugs, older drugs. So sometimes these atypical drugs, okay, they are more effective and less toxic than the older drugs. Okay, they are less toxic sometimes than the older drugs. So nowadays, usually we tend to go for the newer drugs. If we have the budget, okay, we have the budget, we have the money, okay, in the department, so we tend to give the newer drugs rather than the older antipsychotics. Okay, because the newer drugs, of course, they are more expensive, so they are more costly. So that's why that's something that limits our use of the older drugs. Okay, let's talk about a bit about the pharmacokinetics of the antipsychotics. The antipsychotics are well absorbed, okay, when given orally, because they are they are lipid soluble, so lipophilic. So that makes them easily enter the CNS and also many other tissues. Plasma protein binding, many are bound. Okay, they are bound extensively bound. Okay, extensive binding to the plasma protein. The metabolism, it's metabolized by the liver enzymes. Okay, liver enzymes, and they have a long plasma half-life. Okay, they have a long plasma half-life, and this allows for once daily dosing. Okay, you can give it once a day. Okay, many of the drugs can be given once a day. Okay, of course, there are many drugs also given twice a day and sometimes 3 times a day, but some can be given once a day. So in some cases, the drugs that inhibit the action of cytochrome P450, okay, so if you inhibit this, drugs that can inhibit, okay, drugs that can inhibit cytochrome P450, this will cause the half-life to increase, okay? So the half-life will go increase, okay, if you inhibit this, because this enzyme, cytochrome P450, is used to metabolize the drug, okay, the antipsychotics. So if you have a drug or you have drugs that inhibit the P450 system, the CYP450, so of course the drug cannot be metabolized and you will increase the half-life of the drug. And other than the oral ones, of course, we have the parenteral ones. Okay, we have the oral ones, oral antipsychotics, and you have drugs that are given parenterally. So sometimes we need the parenteral so that we can have a fast, a quick starting of the therapy, the management, and also also used for depot treatment. Okay, depot, okay. Please say depot, don't say depot, okay. Some of you, when you enter your 4th year, you are going to present this to me, and many of you will say depot, okay, because you were sleeping in your 2nd year of the lecture. Okay, so you say depot, don't say depot, say depot, okay, depot. Just like we have the on TV, you have Home Depot, okay, and other commercials, okay, other advertisements. Okay, you can check this out and check out the meaning of depot. Okay, so depot is something usually we give once every 2 weeks or once every month, and we give it at the area of the butt. Okay, so we give it on the upper outer quadrant of the butt. Okay, so the patients will be queuing up. So we'll inject one by one. So give them their depot. Because usually, because of compliant issues, they tend not to take their medications when they are on their own. So we have to give them the depot injection. Okay, so that it will last for a longer time, and hopefully we can discharge the patients in the ward and see them after 3 weeks. Okay, and hopefully they're not in relapse. They're not relapsing within the next 2 weeks. Okay, so hopefully they are okay at home for at least 2 weeks before we see them again. Okay, and give them another injection. Okay, so with this injection, hopefully we don't have to see them that frequently. Okay, or we don't have to keep them in the ward for too long, and they hopefully will not be bothering the family too much, okay, with their psychotic symptoms. So I think that's all for the introduction. So we'll continue in the next video.